You, sir, need a haircut.
I do.
But
I tried.
just for kicks, you're far enough along. Let it go. Let it go for a while. I say let's do it until we can't see the earlobes. Oh, I'm liking it.
I'm looking like a who was the guy? One of the great big Western Western stars with the gruff voice.
Oh, you're not talking Willie Nelson. You're not Willie Nelson.
Are you actor, deep voice, just white beard, a bit like who did that's Duet with Dolly Parton.
Oh, Kenny Rogers.
Yeah, looked a bit like Kenny Rogers, but not a proper movie star. I was just trying to think who it was. Coburn, but anyway, one of those. That sort of bushy hair, old man's hair.
It's not old man's hair. If you go back to the decent rock music, you definitely bring it on, buddy. How are you? How are things going? How is there a noticeable decreasing trend in your cases and stuff?
Yeah. It's all going in the right direction. You know, cases are down, deaths are down, infections are down. Loads of people are, a third of the population have been vaccinated. So,
are you intending to?
Oh, I've had mine ages ago. My first one. I'll get my second one next month. So,
okay.
But yeah, with the healthcare professionals, pretty much all vaccinated. Just because it's considered bad form not to.
We're just now getting the recommendations that we can start to get together with other people that are vaccinated without masks. I'm going to have to make a little bit of a change here. It looks like I still have my my voice recognition thing on, and I've got to stop that because there we go. And then now what? How do I get you big again? There we go. Well, it's been a while. What was it? One other thing I was going to ask you. Oh, does anybody even care about that stuff that's caused a ruckus, at least with your royalty? Apparently, there's some kind of an interview with somebody over here that people were throwing some mud or something like. I don't know. Is everyone just going that's craziness, or are they actually listening to it?
No, they're that's all. I turn it off, but it's all over the press, all over the media. Yeah. It's a perennial thing here.
Does it seem to you like there is a fairly even play, or are most of the population saying it's bollocks or whatever you call it?
I think it is I don't pay enough attention to it to really get a sense of it. I know that I think it's kind of 50-50.
Yeah.
I think people who want to support one side will support that side, and people who naturally support the other side will support the other side. And
it's like sports.
Let them crack on. Yeah.
I think we're close enough to Vancouver and also to Victoria that there are people who like to act like they care about that whole thing over here.
Yeah.
And I think there are just lots of people who have not been talking to anything but their walls for a long time, and now they're getting out. And if you even look reasonably interested, they have something that they can talk about. Yeah. Anyway, Jeff.
You get that a lot from the patients. Actually, they just want to talk.
I'm allowing you to share. Oh, hey, that's my friend. Yeah. Well, hi. That's not Beth. That is that is Beth. Yeah. Hi, Beth. Nice to meet you again. Beth is the older one. Yeah. That's not Florence.
Yes. Right.
That's Beth.
Yeah.
Hi, Beth.
Beth is 1, Florence is 2.
Beth is what?
Beth is number 1, Florence is number 2, and the boys are asleep.
Oh, okay.
As should you be, actually. Just going to send her on her merry way.
All right, John, impress me, or at least talk to me, because I've been talking to Walls. Actually,
I have to. We have been busy, so I've not really reviewed very much.
Oh.
So I will just flick through some stuff if. This is something that I am not 100% sure how to interpret. Let's go. Let's see. So we're looking at the Achilles here, and the border of the Achilles. Just. I'm just going to see it. I have not really reviewed.
That is the calcaneal enthesis right there, John, that we're looking at.
Yeah.
And that looks like a
possibly just short of the emphasis there. So that bit that you'd normally associate with a bit of Haglund.
Oh yeah. Okay.
Yeah. So the emphasis would start here, and you've got this smooth, normally smooth area, normally curved, normally slightly more curved than that. And when that gets squared off, you associate it potentially with a sort of Haglund's mechanism. And then here, there is just a little bit of breakdown of the tendon.
There are people out there, John, that really get exercised about Haglund's and not Haglund's. I have seen some correspondence, or at least some postings. So what I think I'm hearing you say is that when we go to more of a squared point, that would be Haglund's. If it's more of like a drop-off waterfall, whatever to it, that's not Haglund's. Haglund's was requiring a exostosis of some sort or something like that there.
I am not sure. My feelings are that when I see this sort of straight appearance here, rather than the natural curve coming around here, that's when I see pathology in the Achilles in this area, and irritation of the bursa potentially.
Would you say that is from wear and tear from going over that as they go into dorsiflexion?
Yeah, as they go into dorsiflexion, I think the edge digs in there if it's squared, and this can be, as in this case, much more marked at the as you come on the medial side of the tendon in this case. Well, I haven't looked at it in that much detail, but just squared off.
Oh,
this will be a little bit of fluid.
Retrocalcaneal, the bursa back there.
And the retrocalcaneal bursa was a little bit thickened, you see.
Okay.
What I care about is what's going on to the tendon. And I don't think I captured any dynamic scan, any dynamic clip on this. But when you actively dorsiflex, you do see this impression of this into the tendon, because it is squared off. Because when it isn't the case, you see this nice smooth cam action of the back of the calcaneus, and that's what you don't get with this squared off shape.
I think that what we call a shopping cart to the back of the heel could probably get pretty aggressive on a point like that too, or I think you call it a shopping trolley, don't you?
Yes. Yeah. And in actual fact, I think this patient said that he got kicked in the back of the and but whether or not that was the actual mechanism or not, and it didn't get an awful lot better than this, but just sort of penetration up there. I've described it in my report as possible very small partial tear. perhaps possibly second to a sort of Haglund's mechanism on the medial side of the Achilles.
What did you do for it?
Well, this now I'm trying to remember. I think I pushed it on, because I'm not sure. I think the patient had done lots of rehab, not helped, and was looking for some sort of injection therapy. And I don't offer things like PRP, but I think it needs to be looked at, considered by the sports medicine guys in terms of.
Could you offer PRP? I mean, could you set up a shingle there or at your house and do it?
Yeah, some of my colleagues do, but not many. But yes, people do it. I'm not really interested in that sort of population. I think you have to be interested in. I'm not that interested in the sports population, and at the moment there isn't really, I don't think, the justification for doing it as a business. There will be for some people, perhaps if you're in the centre of London in a big city and you can offer that sort of, you get that sort of throughput. But I'm much more interested in the diagnostic side of things, and that work is less business orientated, for want of a better word for it. Little thing here, just a little something or nothing on the tendon. So this is on the extensor helax tendon. Sorry, I'm just going to cough. Dying quietly here, despite my vaccine.
It does sound like you're not feeling well, John. We can wrap things up a little early tonight because it is late for you. This is extensor, so this is like at the dorsum as we're approaching the talus, or
this is over the first ray.
Yes,
the first metatarsal, and the tendon's running across there, and it's just this little low echogenicity lesion here, which I recommended they send on to the plastic surgeons just to have a little look at it, because I don't think it's a ganglion.
Your eyes saw that it was not anechoic, and your eyes saw what else that made you say that? And was it active at all on vascularity?
There was no vascularity on it. No, I've not recorded anything.
Did you go short axis there in a bit later on? Is that what you showed me?
Yeah. So that's the long, this is the short. There's back to the long. Sorry, I've only saved, I took quite a lot. Yeah. I looked at this quite a lot with different frequencies. I've just taken a little bit. There's some solid component. There's not a lot of posterior enhancement. So it's and the boundary, when you have something that's fluid, then the boundaries should be pronounced. Your fluid solid boundary should be unambiguous because of the difference in density, and this just isn't. It's, as I say, you'll normally see some sort of capsule, for want of a better word of it, if you have a cyst. Just the nature of the business, nature of the beast.
That's very valuable to me, John, especially how you're using the posterior enhancement to decide whether or not there is enough fluid, or what is the component of liquid to that.
Yeah, you can't say something is liquid because it's got posterior enhancement, because that's a classic error. You get a lot of vascular lesions that actually have so much fluid in them they let sound through like a sieve.
I think what you're saying is, well, Greg, that clarification that you just said, it doesn't even hold any any water, quite honestly. So it might not be a clear fluid, or
it's more the other way round. I'm more convinced it's solid because there isn't a lot of enhancement there. It wouldn't, just because there was enhancement there wouldn't make me think it was fluid. It's when there isn't any enhancement, then I'm more, if I'm unsure, then I'm more sure that it's because there's no enhancement behind it, or not a lot of enhancement. Because something that fluid, I would expect to be bright behind there, and that would vary when you look on color, as I think we've spoken before, and I haven't got a clip in color. Then you don't get the cross hatching of the compounding, and so the posterior enhancement is much more obvious at that point. So when you look at your color box, as we've discussed in the past, when you put your color on, you will generally see posterior enhancement is enhanced. So whereas on an image like this, where you've got lots of cross hatching, you've got threes, that's actually a composite of 3 pictures with different angles of insonation. So the posterior enhancement can be disguised to a certain extent from that, but you'll still get some.
Let me ask you this: if the composition of, let's say, a Baker's cyst is something that is not septated, let's say the composition of the Baker's cyst is becoming more gelatinous, more like agar or something like that, will the level of gelatinicity change the posterior enhancement? Or is that not, that's what you're saying, is it could be, it does not have anything to do with the thickness or the viscosity of the material inside the cyst?
Not very much. No, not very much at all. I'm not sure the gelatinous nature of a structure has a very big effect on its density. Anyway, if there is an effect, it's very small, because I aspirate cysts on a daily basis, and most of them are ganglion-like. Most of them are extraordinarily thick, and yet acoustically they are identical to water.
Wow, what about elasticity? When are you going to add that to it so that you can become the expert on elastography?
Well, up until now, I have yet to see elastography have any practical purpose in MSK. It's just not up to the job.
I hear you, but I want to hear what this is. Are we talking the side of the talus where we're looking?
This is the posterior joint. I routinely look at the posterior joint line in an ankle
for capsular fusion in the ankle.
Fusion, or as in this case, if I can find it again, just tapped off it. Loose body. So this was just a little loose body up here, and I think it had been called on X-ray. It had been called a os trigonum.
Oh,
it was quite clear then. They thought it was an os trigonum, but when you look at the ultrasound, you can see it's mobile in the capsule, intracapsular, and mobile, and so clearly not.
And you would not call this like a fracture debris from, what do they call those things when they grow together at the ankle? It's a word that podiatrists like to use to say that it's osteophytes that are coalition.
Coalition? No. Anyway, this is just a little mobile. Just to make out that it's moving, and that's as I move the foot, it twists around. No, I don't think so. For some reason, they've just dropped off they've got themselves a little loose body in there. It's either calcified or there's been a chondral injury, more likely, and it's sort of calcified, would be my best guess. I'm not sure what this one is. So just a quick look. The ganglion. Yeah, this was just by the by. So this is the insertion of the pec major, and you're going to see quite an untidy looking biceps come in just a moment. Coming down here. Now, I'm going to try and convince you that that is all biceps tendon.
Okay.
Yeah.
When you say biceps tendon, you're saying that you believe that to be intrafibrous effusion in the actual long strands of the biceps tendon, as opposed to that being free fluid.
Yeah, yeah, it's contained. This is like an intratendinous cyst or intratendinous ganglion like formation that is spreading out spreading out of the tendon and into this area here.
Can you mark where you believe that the collagen of the actual biceps tendon is in that picture?
Yep. If you go up there, you see that thin rim.
Yes.
I think that is all biceps tendon.
Wow. So it has the same cross-sectional area from a tensile strength standpoint. It's just it has within it a lake.
Yes. And then this one has ruptured. The tendon has ruptured and reattached. This is the lesser tuberosity.
The tendon has ruptured and reattached.
Yes, and it has and there is ganglion formation within it. So it had some sort of split, which way round it happened, but it's split. I don't know how much, whether I took a long section of it. Now I'll just run up again. I might have turned on it there. But yes, it was not an easy scan. It was not a particularly pretty scan. But this is not sheath. This is tendon.
Wow.
With a ganglion in it. I don't know whether have you ever seen any ganglions within tendons?
I have not.
All right, you get them. Hernias brevis is a good place to get them.
Hernias brevis.
Yeah, funny enough, I've seen a couple there, but they're not common, but you do see them.
And you just let them have a life, or do you try to do something to them?
Well, the things I've tried to do to them have never really helped. So I tend to tell patients that and say I can stick in this case it wasn't symptomatic. It was part of a very complicated shoulder picture, OA shoulder picture. But I just happened to notice this sort of big old ruptured biceps, because you often see biceps ruptured and reattached.
Well, I need to spend some time with you on that concept of what you just said. When you say reattached, are you talking that the free endings are coming together and that reattachment is occurring like the Achilles tendon is attaching, or are you talking like it has avulsed, so there's a cortical island that's come off and that bone is reattached? How about I listen to what you mean?
What I see is a biceps tendon that is ruptured and then seems to stick down onto the lesser tuberosity.
It has ruptured from where it comes from the glenoid up and over the humerus.
I very much doubt if it pulls all the way back. I don't think these are avulsions.
Mid-fiber tear, and yet it has simply laid onto the lesser tuberosity, and it has tenodiced, or it has had its own reattachment there, like they do surgically.
Yep, and you see that not infrequently.
And when we load it, like under load, it holds pretty fast. And
seem to, yes. I can't say that I've ever done anything scientific about it, but you know, it isn't an uncommon finding. Certainly.
It's interesting because that Steve Bird or whatever talks about that there is a enveloping collagen whatever sheath that holds it, and that it can sometimes be tethered to that, like it's almost like at the distal biceps where they have that aponeurotic type thing, but anyway.
There's usually a little ligament. If you get a nice effusion, there's usually a little ligament that joins the biceps tendon to its sheath. And but I'm not sure that's the same thing. If you look, I don't know whether we can see it here. Yeah, you're following. If you're taking my word for it that this is tendon,
yes,
you'll see that it comes into this bony thing here, and that's as far as it goes. And that's all I've got for you. I'll try and find a much more straightforward one, and next time I see one, I'll make a point of recording what you see, and that's how I interpret it. So, I'm not sure that anyone's written too much about it. Let's stick to stuff that's recent.
John, I need you to know that I'm perfectly fine with you saying you're having chills and you need to go to bed.
Well, I might go to bed a bit early.
Okay.
Talking of, now I have no great wisdom in this case, but just on the subject of biceps and of stuff in the biceps sheath. Can you see that the biceps has a little neighbor there?
Yeah.
What that is, I don't know. You know, it looks like a little fatty deposit just there. Texture of it looks like fat, but equally, and I had no reason to think it would be tophus, but you know, that's the sort of thing that would go through your mind.
Tophus is a component of a of gouty type stuff, right?
Yeah. Yeah. This was just a little tricky full thickness tear. Surprisingly, I must have been having trouble seeing it because I've had to approach it from an awkward angle, which is why you're not getting the thing, which is surprising because it's quite a large tear. You can see there's the defect in short axis. There are some fibers crossing, but just more proximally. It's quite nice.
Whoa.
It always makes you feel good when you see a tear like that. Not for the patient, but you know, unambiguous. You know, that's one for the surgeon, I think. But the small partial thickness tears, I think, are more difficult to call. So just there. How well is that imaging coming across?
Coming across fabulously. This is so incredibly relevant because I just saw a patient yesterday that had something very similar to this. I was going to ask you, it did not look very new in the patient that I saw. And I'm asking you, how much do you place on the short axis muscle belly to determine the level of functional loss from something like this?
Well, when I see something like this sort of small tear, I don't expect to see any change in the muscle, in the body of the muscle belly. I would expect this to be not necessarily irrelevant, because it might be sore, it might be, but this is a very small part of the supraspinatus.
So,
and when they look new, this could be a little bit new. There's some fluid filling in. When you don't see any fluid filling one of these defects, and you see this in a 70-year-old patient, you kind of think, this is natural history, because this is not the front portion of the tendon. We go back, if I get to a point where, if I've looked at that biceps is right over here. That's the anterior part of the tendon. That's the structural solid part. Yes. This is right back where infraspinatus is coming across. You could even argue that might be a bit of infraspinatus. This is not, in the non-throwing athlete, I'm not sure this area is terribly relevant in the older patient. So I would not be looking for that to be clinically significant. Certainly not significant enough to get you for it to go on for 6 months, and which is what it takes to come to get into my clinic generally.
Are you satisfied with that, or would you like to get into more of a sooner scan, or are you?
I don't know. It depends on what, some things come through really quickly, but the supraspinatus injuries, your classic impingement type pain, they get managed so adequately by everyone before imaging. So you don't necessarily get imaging very early in these cases, and the imaging doesn't really matter, I think, necessarily in those non-traumatic cases. What really matters to start with is, understand that classic understanding. If the clinician has made that three-way split, we always argued. I remember famous surgeon in England, a guy called Tim Bunker, down in Exeter, now retired, but he did a lot of the primary research on frozen shoulder. So he did a lot of the biopsies on frozen shoulders for the primary science. And he always used to say, there are only 3 shoulders. That a stiff shoulder needs an X-ray. A shoulder that hurts as you lift your arms up like this needs an ultrasound. And any suggestion of instability needs an MRI arthrogram. And, so you walk into, his attitude was, you walk into clinic, you fit into one of those 3 groups.
That's reasonable, man.
Yeah. I used to have good fun with the juniors when they would come with all their complicated ideas of assessing shoulders. And I'm just going, no, you've got three basic, you want to work out one of 3 things. Is it unstable? Is it stiff? Have you got that sort of impingement thing? And then your basic, if they fit into that more impingement picture, then you're trying to see if you can get, first off, you're just trying to get the cuff to function properly. And it really doesn't matter in a non-traumatic case, something that's not spectacularly wrong, they can't lift their arm. Trying to see if whatever's happened to the cuff, whether you can settle it down, whether you can calm it down in the initial stages when they first present. And if they do, then they're probably going to do all right without imaging, because there's no point in operating on something that has good function and where the pain goes away. So that tends to be our perspective here. It's only when that cycle's not gone through, when that's not worked out, that then it becomes very relevant to do it. That's not to say if you turned up at my door and said, John, I've got a sore shoulder, I would scan it. But the actual clinical judgment would be, the ultrasound would just make me happy that nothing major had gone on there, that there was nothing surprising going in there. And then it would be about, well, let's see what your function's like. Can we get the function there? So in the UK, at least, that's what happens. You get treated clinically to start with, and it's only if you fail that, then you come into imaging. For shoulders, I would see a lot of irrelevant stuff if I was seeing it much more acutely.
you would see a lot of irrelevant stuff because they have not been appropriately triaged for you to be able to see structure that you know is going to be damaged.
Yeah, well, no, it's more, you turn up in your 60s and 70s, which is the bulk of the shoulders that come and see me, and you hurt it. You do something small, you hurt it, and look, and I see you've got a full thickness tear, and then it's all, do you need surgery? And like, I can scan the other side, and it'll also have a full thickness tear, and so you haven't got that relevance. It's to get the full picture in terms of rotator cuff, you have to know how it responds over a period of time. It isn't just whether it's sore and you've got a full thickness tear. Has that full thickness, is that full thickness tear then causing an ongoing problem? And you don't know that in the early stages. So the ultrasound is less useful in that population, which is my population. Are
they using reverse total shoulder arthroplasty there? And what is your opinion on, we're getting some docs here that are basically saying, we don't want to sew on old canvas. Just wait until you have a little bit more degenerative arthritis in the joint, and we'll put a new shoulder in there, and we'll use the deltoid to function as your rotator cuff. Do you get any of that over there?
Yeah, I don't know about, not necessarily that sort of discussion, but we don't see a huge number of shoulder replacements. We don't get a lot coming through, and where I am, there's some very enthusiastic reverse geometry surgeons. So they do them. They clearly do well enough not to present very often. They don't often come and see me.
Do you do much post-surgical imaging, hardware assessments and stuff like that, John?
No, not at the moment. Not anytime recently, because I work mostly in primary care, and so we see and we manage shoulders so successfully. I think in primary care we send very few off to surgeons, but then we're not doing the imaging for the surgeons, and so there's talk of it from time to time, but I'm not up to date with any of that, and it changes. I remember a few years ago when we did look at stuff, we were looking at the implants where they were putting in cuff replacement, little sort of
that netting or the
dried apricots.
Yes.
They were putting in the shoulders, and I think it was early days for them, and obviously the ones that don't do well are the ones that came to us. So I haven't really seen it. It's not one that gets talked about a lot, and so I'm presuming that it never really made the grade. But occasionally you get people showing up with one.
In this view that you have here, can you again with your pointer give kind of the real estate that you would say would be the anterior and then posterior and then infraspinatus in your opinion?
Yeah. Let's look. I think this is probably biceps. Yeah.
Yes.
And this layer here is probably the deep layer of the supraspinatus, and this layer here would be the anterior supraspinatus, and then it's probably starting to thin in this area, and our defect is here, the boundary between the infraspinatus, which is probably this thing over here. But this scan is not a good example of picking out the fibers.
If I required you to guess a cross-sectional area percentage of the whole of the supraspinatus tendon, would you say that the lesion has compromised 10 to 20%, or would it be 5 to 10%? What would it be?
Well, I'd be working it out because I don't think in those terms at all. But
okay.
But yeah, that's a half. So that would be a quarter.
Yes.
That would be an eighth, and it's probably a fraction of an eighth.
Okay.
Yeah. I don't think it's very big. So yeah, so it's pretty small. but it's fluid filled, which makes me think that there's some sort of pull, some sort of trauma to it.
Would you put any anesthetic in it? Would you put any type of anti-inflammatory in it, or would that all depend upon the patient's level of pain?
It would depend on what I think was going on, really, because I wouldn't aim to put any steroid in that tear, because steroids are a very good way of turning a small tear into a big tear. And unless of course unless I was going to get paid for the surgery, for the surgical referral, as a kick. I can't really see the point in doing that, and we haven't got to that level of ethic. That said, we inject a lot of partial tears. We inject a lot of shoulders with a partial tear, because we see a lot of partial tears that aren't necessarily the cause of the pain, and the patients have failed rehab, and they have and they don't want to go to surgery, or surgery is not appropriate for them. And at that point, we have the conversation. We say, the steroid that we're going to put in your shoulder is going to be harmful to the tendon that's there. We don't think that is necessarily catastrophic for you, and this may allow you to sleep for the next 8 weeks when you aren't at the moment, and your tear may never progress to a point where the shoulder ceases to function because of it. And if we calm it down, you'll do better.
Your injectate will be simply placed into the breech crevasse?
No, into the bursa.
Is it in the subacromial region, or where is it?
You just inject into the subacromial region.
Okay, all right.
And the fact that communicates, if it's a bursal side tear, which they often are, is an unfortunate consequence of that. But for some patients, that's what we deem and agree is the most likely to be helpful when they've failed. But I am very reluctant to do that unless they have failed rehab and are not going to go to surgery and have symptoms that they don't want to live with, and they want us to try to do something about. And so we have a limited arsenal to do about that, and so that's our choice. So this is just a subtle one. This is we're looking at subscapularis dynamically here, and this is quite a large distended subcoracoid bursa.
Did you say this was a subtle one?
No, the picture is subtle because the story is subtle because of this.
I don't understand then the word subtle.
Subtle is that this is not subtle at all. This is a massive collection there that is trapped. So it's almost like a ganglion or something like that. It has that sort of resistance. It's not like normally the bursa just flows out, but this is like a contained sac, a proper bursa. But if as I rotate the arm, you'll see there is just a flake of fluid there, which is in the subacromial bursa.
Wow. You said the other one was a subcoracoid bursa. We would expect to see that showing up under the coracoacromial ligament, or where would that be?
The coracoid is here.
Yes.
This is subscapularis.
Yes. Long axis. Yeah.
And so there is a bursa-like, but a big encapsulated bursa.
Oh, okay.
That is getting pushed under, but it is separate from the subacromial bursa in this case.
Yes.
So you then ask your question: Is it one of those cases where they are separate, and it's got swollen, or equally, and it'd be difficult to tell the difference between them, but you can get blistering and sort of ganglion-like formation under the in the undersurface that sort of peribursal tissue. Whether those two things are actually different, I'm not sure. But it just caught my eye as I was scanning through. I was going, whoa, that's a nice bundle of fluid. And I thought, oh, I shouldn't see that separate. But you can see it is separate, because if that communicated, then it would swell up and you wouldn't get that shape of bursa. So, and I didn't put a needle in that, but that would have been my temptation. I would just aspirate that as a self-contained thing that would clearly interfere. That swelling as it's going under the coracoid and the coracoid brachialis will just be interfering to some extent in the mechanics. And when fluid does, then I think it's a good call just to drop a needle in there and just pull it out.
Now, what you see there, is that going to come out like molasses, or is that going to come out like water?
You would expect it to come out like water, but it would come out like, but I would bet that it came out like molasses.
Huh.
When you get a big effusion of the shoulder, so a classic OA that's just blown up like a balloon, they come out and they look like they've had some sort of beauty therapy on their shoulder to make it gone wrong, that sort of thing. Usually and that's classic appearance for your 85-year-old rheumatoid patient, has this classic swollen shoulder. You stick a needle in that and you could hose the wound down. Fluid that comes out sort of like that. But these when you stick your needle in, and these articular structures, I find I would be actually quite surprised if it wasn't like pulling out glutinous jelly.
Do you then go with a huge bore needle?
Yep, I use what's called an 18 gauge, which is we do them right.
They get bigger as they get smaller.
As the number gets smaller. The typical injection for any deep structure is 21 gauge. And how big is a 1? I don't know actually. I've never heard of a 1. I think you use 1 to get rid of sewage.
you use 1 to put the scope in. That's about probably the size of a.
Yeah, I'm not sure. What we go 18 gauge in millimeters. So an 18 gauge is is 1. No, that doesn't sound right, but I thought they were bigger than that. But it's a big old needle. It's nothing like the needle you do to take blood or anything like that. It's a thick old needle. I'm not sure. I've got probably.
That's okay.
But it's it's the sort of needle you have to push to go through the skin.
Yeah, I just got to come over there one of these days and watch you, because that would just be so fascinating to me. But it wouldn't do anything other than to make me go, whoa, we just a different skill set there, buddy.
Yeah. But in the UK for physios, that's doing the injections is a big part of the work for a lot of physios in these days.
I want to let you get to bed, buddy.
Yep, I think I'll let's call it a night because I'm feeling pretty ropey.
Yeah, I'm sorry about that. We'll connect.
I have taken my test and I'm not COVID, but
well,
the kids have all been running around with so
good talking to you, buddy. And I'll reach out again and see if we're on for next week. But for now, let's plan on it, and I'll hear from you one way or the other.
Yeah. See you later.
Take care.